Hello friends, welcome to Hip and Knee Clinic, and today we will, and first we'll see the anatomy and mechanism of injury and deforming forces. So the proximal humerus is made up of head, neck, lesser tuberosity and greater tuberosity. There are the four part. And what are the deforming forces? So greater tuberosity has attachment for supraspinatus and intraspinatus and teres minor, that is a rotator cuff, and lesser tuberosity has attachment for the subscapularis, and proximal humerus shaft has attachment for pectoralis major, that will pull the fragment medially. The GD will be pushed up superiorly and posteriorly, and LT is pushed medially by the subscapularis. So vascular supply from the circumflex humeral artery, and the anatomical neck has very poor vascular supply. So there is any fracture to anatomical neck, there is high chances of avascular necrosis of the humeral head. What are the mechanisms of injury? So trauma and fallen outstretched hand, and in older age group it is very common due to fall on the floor, that is household trauma, and female get more fracture than male, and young patient will get fracture due to the road traffic accident. Clinical evaluation: patient mostly having a pain, swelling and deformity, and there is a ecchymosis sometimes, and we have to examine axillary nerve for any neurological injury, and in radiograph we can take X-ray, AP view and axial view, and in the comminuted fracture we have to take CT scan of the shoulder to see for the fracture configuration. And these are the classification based on the four part, that is one is the head, then GT and LT and shaft. So these are the four part, and classification is 1 part, 2 part, 3 part and 4 part depending on the fracture fragment. So if fracture is displaced more than 1 centimeter and more than 45-degree angulation, then they are considered as a part. This is 1 part, and this is the 2 part, and this is 3 part, and this is 4 part. So the GT is separate, LT is separate, head is separate and shaft is separate. So what are the management? Most of the proximal humerus fracture can be treated conservatively in the arm pouch, and operative indications are the young patient, and with GT and 2 part fracture, there is GT displaced, we can treat it as a operative management. And now in recent scenario, in old age patient up to 3 to 4 part fracture we can fix with proximal humerus interlocking osteosynthesis, that is a Philos plate, that is a very stable construct, and provide the stable fixation and allow for early mobilization. And most common complication is stiffness of the shoulder. Whether we operate or will conserve, complication is rate is too much with the head, and stiffness of shoulder is the main problem, and sometimes malunion, then non-union avascular necrosis, and there is a sometime neurological injuries. In operative fixation, there are we can fix it with K wire, we can fix it with the plate, and in severe comminution we can do hemiarthroplasty. Hemiarthroplasty provide the pain relief, but functional outcome is limited. So we have to explain everything to the patient. Thank you very much. You can put any queries in comment section.